known figure oncology, professor of oncology at the Antwerp University in Belgium, who is going to talk to us about the clinical implications of personalized medicine in metastatic colorectal cancer.
Thank you very much for that kind introduction, and it is absolutely a pleasure to give you some insight what is the clinical implication of these new data on KRAS and RAS in our routine clinical practice. So I think today we have different options to treat our patients. You have, for the moment, the surgery that is becoming much more aggressive than before. You have the surgery of the primary tumor, but also more and more patients are getting surgery for metastatic disease. We have also the possibility to treat our patients with organ-directed treatment, like chemoembolization, radioembolization, and in certain centers within Europe and in the US, patients getting external beam radiation for liver metastasis. Over the years, we made a lot of progress in the systemic treatment. Not only new chemotherapy was coming on board, making improvement in the outcome of the patients, but like you heard by the previous speaker, we also introduced targeted therapy in the treatment of patients with metastatic colorectal cancer. I think Professor Nadia convinced you that the pathology is playing much more a role in guiding our treatment decision today than before. For me, it's clear that we are moving from the routine pathology to more and more molecular pathology that is the base for our decision what treatment option that we will give to our patient. Hopefully, also in the future, new imaging tools will play an important role to decide what patients have the right profile for the right treatment. So like I said, years ago, we treated most of the patients with 5FU, and these figures are well known. We had a median overall survival of around 6 months, 8 months in the best cases. We had the introduction of chemotherapy, newer chemotherapy, irinotecan, oxaliplatin. We moved upwards to 16, 20 months of median overall survival. And what is also important, in view of the resection of patients, the increase of response went up to 40-50%. But this is the situation today. You have the chemotherapy backbone, you have the biologicals targeting the VEGF pathway, and you have the biologicals targeting the EGFR pathway. And in most of the cases, we are combining these treatment options. Everybody knows the combination with FOLFIRI and bevacizumab. We know the combination FOLFOX plus panitumumab. But in certain cases, even today, in the setting of maintenance or in patients becoming chemo-resistant, there are some molecules that have benefit of treating with monotherapy, for example, with panitumumab or cetuximab or regorafenib. Putting all these options together, it's becoming very difficult. And these are the ESMO guidelines. Most of you know them. We have different options, and the question is how to choose the right strategy in a given patient. And to do that, we have to take into account a lot of factors. The first factor is the clinical presentation. Is it an aggressive disease? Is it a disease with one lesion in one metastatic site? These are the features that give the base to the decision what strategy in a given patient. It translates in the fact that you are going for an aggressive combination therapy or to a more softer, for example, monotherapy with capecitabine. Not only the presentation, but different other factors are playing today a role in deciding what systemic treatment for a given patient. You have the efficacy of your regimen, you have the importance of quality of life in patients in the palliative setting. You have reimbursement issues, not only here but also in Europe. We don't have all drugs available because they are not, we can afford them from an economic standpoint. We have the biomarkers that guide our decision, and then you have patient-related factors. If a patient is living 200 kilometers from a cancer center, it might be a better option to go for oral treatment against intravenous treatment. Let's move now to a translation to the clinical situation. And we had a discussion on the early age in Egypt, but also in Europe, we have non-familial cases, non-genetic cases with an early onset. And I have the impression that, especially in rectal cancer, the age is going down. For example, this is a female patient, 39 years old, no comorbidity, no clear family history, presenting with changes in bowel habits, was prepared for colonoscopy, went into obstruction, get a resection, and an adenocarcinoma, PG1, T3, N2 was detected. Further evaluation was done, and this is a CT scan, different lesions in the liver. This is a patient with T3 tumor with metastatic disease in the liver. And so at that moment you have the multidisciplinary team discussion. Is this a patient that can go to resection of the metastatic lesions? Do we need markers at this moment to decide what treatment option? What is the strategy? Are we going immediately to surgery, or are we starting with chemotherapy and then go to surgery? So different questions has to be asked to ourselves and to be answered by the multidisciplinary team. Another case, 35 years, no comorbidity, a second-degree relative with colon cancer at the age of 50, atypical presentation, during some months different symptoms, and in October 2011, presenting with constipation, fever, and weight loss. And these are the lab values: high LDH, high CEA, colonoscopy showed a stenotic tumor at 25 centimeters, adenocarcinoma, and these are the scans. It's clear here is no discussion about surgery of the metastatic lesions. This is clearly a palliative situation. But again, we need to answer some question. Is there a place for resection of the primary? Are biomarkers necessary at this moment? What is the strategy in this patient, and which type of systemic treatment? So, based on the presentation again, you can make a decision whether this is a diffuse metastatic patient, where you go for a palliative treatment, where the balance between overall survival and quality of life is important, or a patient like the first case with limited disease, where we need induction therapy, neoadjuvant therapy, and then go to surgery. Let's move now to the biomarker story and the impact on the clinical strategy. As you know, when treating patients with EGFR inhibitors, and not only in colorectal cancer, and not only with antibodies, but also with small molecules, it's clear that there is a relationship with skin toxicity. The higher the intensity, the better the outcome. This is not only seen in small molecules, but also in antibodies such as panitumumab. And these are data from the PRIME study, where you clearly see a correlation between intensity of skin toxicity and outcome of the patient based on the response. But this is not an easy biomarker to be used in clinic. It's difficult to decide on skin toxicity, whether you go further with treatment, whether you increase the dose or stop the treatment. So we need something more objective. And then we are coming back to the molecular pathology behind the evolution in colorectal cancer. And one of the key players, and this was already said by the previous speaker, an early event is the KRAS mutation story. And therefore, some years ago, in 2008, we looked, based on the first panitumumab study in chemo-resistant patients, what is the role of the KRAS in the outcome of these patients treated with panitumumab. And it was clear that there is an impact. If you look to the wild-type population versus the mutated population didn't have any benefit of the treatment with anti-EGFR, more precisely with panitumumab. This was not only seen for the monotherapy, but also in combination study, first line with FOLFOX, second line with FOLFIRI, and also second line in combination with FOLFIRI with panitumumab. So there is clearly a negative predictive benefit of having the determination of KRAS status in these patients. And the message today, based on these data, was you need determination of KRAS status before treating these patients with anti-EGFR. Let's look now more in detail on the data generated with FOLFOX and panitumumab in first-line setting. The primary analysis, which was published in JCO in 2010, clearly showed a benefit in favor of the combination with panitumumab in patients with wild-type tumors for PFS. There were updated data, and the last update was the 80% event update, which was presented at ASCO, and this is the overview of the results. On top, you see the median PFS, where there is a benefit of adding panitumumab to FOLFOX, statistically significant. In absolute numbers, there was a benefit of 4 months in favor of the combination. And going to the updated analysis, this became statistically significant. And this is also translated in the curves. If you look to the curve in blue, which was a combination with panitumumab and FOLFOX, against the curve in yellow, FOLFOX, it's clearly that they are splitting over time in favor of the combination, and it became statistically significant in favor of panitumumab and FOLFOX. Also with regard to resection, as you remember, resection of metastatic disease is an important point in the treatment strategy of our patients. So if you have a regimen with a high response, you can have a lot of patients going to resection of their liver metastasis and even combined metastasis, because we are going to resection in some cases of the liver and also of the lung. So these are data with panitumumab, again, is based on the prime, 57% response rate, 61 patients with liver-only metastasis, and 28% of these patients had complete resection of their liver metastasis, in comparison with 18% when only chemotherapy was used. Not only in first line, there was an additional value of panitumumab to FOLFOX, also in second line, and I'm proud to be the PI of that study. We clearly showed that there is a high response, 35% in the combination with FOLFIRI and panitumumab. You have a benefit in PFS and an overall survival benefit in absolute numbers of 2 months in favor of the combination with panitumumab. There will be an update next week at ASCO GI on the impact of going from KRAS towards RAS determination on the outcome of these patients in second line. So based on all these data, 1 year ago, this was the algorithm. Clinical presentation is important, but also biomarker presentation is important. If you have a patient with mutated tumor, first, second, third line, these are the options. If you have a patient with wild-type tumor, you have several more options. For example, you can treat a patient with chemotherapy or become more aggressive with a regimen with high response. For example, panitumumab with FOLFOX in first line, but also in second line, anti-EGFR play an important role in the treatment of these patients. There was already some details on the different mutations in the KRAS gene. and the importance of the frequency of G13D mutation. And there were some data that these mutations in G13D might be patients that could be treated with anti-EGFR because they were sensitive. And this was based on a heterogeneous population treated with cetuximab, published 3 years ago in JAMA, where there might be a benefit in the outcome of treating these patients with cetuximab. We also looked in more detail in all the data that we have available with panitumumab, and it was clearly shown, especially in the frontline setting, that there is no benefit of treating these patients with anti-EGFR. It's clearly in red, G13D mutation had no benefit of adding panitumumab to FOLFOX. Let's move now to the discussion on what is the best strategy. Do we use an anti-EGFR in frontline or an anti-VEGF? And this is the study, a phase 2 study, the PEAK study, but you also know the FIRE3 with cetuximab. But this study is focusing on the combination panitumumab plus FOLFOX versus bevacizumab plus FOLFOX in patients with wild-type KRAS tumors. Primary endpoint was progression-free survival, and this is the curve that was generated. There is no difference between both arms, based on KRAS status. As discussed by Professor Nadia, we went downstream and looked what is the importance of the other genes in the outcome of the patients. And two things were important to generate the data that I will present in a few minutes is, first of all, the enormous amount of tissue that we had available from the first, second, and third line study with panitumumab, and second, the technology, based on the next generation sequencing technology, based on the fact that we can test one sample for different genes, made it possible to generate this important data. And this is the study on the monotherapy data, where we looked for different genes that are important in the downstream sequence when you are treating patients with anti-EGFR. In the first column, you see the patients in the panitumumab plus best supportive care arm. Then you had an extension study, and the last column is showing you the combination of both patient groups. And what became clear is that, for example, RAS is playing an important role. If you have a mutated tumor in RAS, there is no benefit of adding panitumumab to the treatment of these patients. BRAF, also no response, but there still the question, is it predictive or prognostic? For the other mutations, it is less clear. And that's the reason why we focused further on the importance of adding KRAS analysis and the analysis on RAS to determine the outcome of the patients, not only in these chemo-resistant patients, but also in the PRIME study and in the phase 2, the PEAK study in frontline setting. So let's focus on PEAK. As you remember, this is a phase 2 study, randomized panitumumab FOLFOX versus bevacizumab FOLFOX, and we looked for the incidence of other mutations outside the KRAS codon 1213. And it's clear that an additional 18 to 20% of other mutations were found. 11% in the KRAS gene, exon 3, exon 4, and another 11% in the RAS exon 2, exon 3. 6% of the tumors had a BRAF mutation, which is important because it's telling you that the technique is robust. This is clearly in line what you could expect from literature. What is now the impact on the outcome of these patients? On the left side, you see the determination of KRAS exon 2, wild-type tumors, no difference in the curves. If we look now to the impact of further analysis, and you are looking to the RAS wild-type patient population, it's clear that the curves are splitting in favor of the combination with panitumumab and FOLFOX. This is not only true for PFS, and we have to be very careful because the study was not designed, but it is a proof of concept. Also for overall survival, the curve is splitting in favor of the combination with panitumumab if you better select your subgroup that gets the treatment. The median overall survival in that population with panitumumab and FOLFOX was 41 months. So putting all these data together for the PEAK study, you see that the median PFS for the combination panitumumab and FOLFOX based on RAS status is 13.1 months, and the median overall survival 41.3 months in favor of this combination. Going to the phase 3 study, FOLFOX versus FOLFOX plus panitumumab, we have the same story. You see that another 9% of mutations are found outside exon 2. Looking to RAS, another 8% of mutation. So in total, again, around 18% of additional mutations were found. So what we see is that before it was a 60-40 rule, and this is in line what was presented for Egypt. 37% had a mutation in KRAS, in general 40%, so there was a 60-40 rule. Now we are moving towards a 50-50. 50% of the tumors are mutated in RAS versus 50% are RAS wild type. So we are better selecting our patients. And this is also proved, and this is a publication in New England of last year. If you have a patient with a non-mutated RAS for progression-free survival and overall survival, these patients are really benefiting from the association panitumumab plus FOLFOX. So, putting that in perspective, looking to the overall survival, you have a patient with no RAS or BRAF mutation. They have a median and overall survival of 28.3 months for the association panitumumab plus FOLFOX against FOLFOX alone, which is 20.9 months. So a difference of 8 months in favor of the association when you select your population very carefully. So we are really moving further in improving the median overall survival of our patients with metastatic disease. Another question is there a difference between the antibodies targeting the anti-EGFR pathway? And this is the ASPECT study, a head-to-head comparison between cetuximab and panitumumab in the monotherapy setting, chemo-resistant patients, more than 1,000 patients randomized based on the KRAS status. Overall survival was the primary endpoint. And looking to these curves, there is clearly no difference in efficacy. Also, when looking to response, you see 22% had an objective response for panitumumab, 19.8% for cetuximab. What about toxicity? In general, no big difference. But looking in more detail, you see that there is no difference in skin toxicity overall, that there is somewhat higher hypomagnesemia with panitumumab, but not clinically important. And of course, although these patients received pre-medication, infusion reactions are higher with cetuximab than with panitumumab. There is another study in Brazil that is looking again to the question, and based on KRAS wild-type status, what is the benefit of panitumumab versus best supportive care? And their overall survival is the endpoint. What is the reason of that study? Because in the 408 study, the first study, there was a lot of crossover. In this study, crossover is not allowed. And these results we are waiting for 2014. So translating all these data into clinical practice, it's for sure that we move from KRAS determination towards RAS determination. And this is the base to decide whether you go for a treatment with anti-EGFR, yes or no, in your patient with metastatic colorectal cancer. Based on all the data that we generated in different studies, based on the biomarker analysis, it's clearly that in RAS wild-type patient, you can use panitumumab in different settings, first line, second line, and in monotherapy in third or fourth line. Ladies and gentlemen, I think there are three important points to treat our patients with metastatic colorectal cancer. We are not treating these patients alone. It's not the oncologist, the surgeon, or the radiation oncologist. It's clearly a multidisciplinary teamwork at every time point in the evolution of the disease of the patient. It's clearly personalized. With the new biomarker data, we are more focusing on subgroups, having a better outcome with regard to response and overall survival. And it's also a question of expertise, because it's becoming much more complex. If you look to the treatment algorithm proposed by the ESMO, you need expertise to decide what treatment at a given moment. And based on that, for sure, the patient that I presented with, that young patient with diffuse metastatic disease, will be better off today than in the past. And hopefully, in a few years' time, we can state that metastatic colorectal cancer, like breast cancer, is becoming a chronic disease. Thank you very much.
Thank you, Professor Mark Peter. It is time for question. Professor Ayman?
Excuse me, a small question,
Yes.
just a small question. Thanks a lot, Professor Mark Peter, for this high-quality presentation. And I would like to have your opinion as regards the ASPECT study, which is a head-to-head study comparing cetuximab to panitumumab. There was no difference in overall survival response rates, and even more or less the same toxicity profile. So, on what basis should we define a certain drug to a patient?
Yeah, I think it's important to state, first of all, if you look to the way that we are giving both drugs, it's still a difference. Because normally, if you look to the guidance for cetuximab, it's weekly regimen, and panitumumab is every 2 weeks. Second, you don't need a pre-medication for the patients with panitumumab against cetuximab, although there are still some infusion reaction. But with regard to efficacy, it's difficult to state what is the better drug. They have the same efficacy in monotherapy.
Yeah, thank you. I think this may be a question in the minds of many of us. Thank you.
Professor Ayman?
Thanks for your presentation. I have two questions. First one, you said that only the KRAS mutation which affects the response to anti-prospective treatment also have the NRAS and the BRAF. So in your practice, did you do all this mutation or not? This is the first question. Second question is, in ASPECT studies, they make head-to-head comparison between the two the pani and the cetuximab, and we said that the infusion reaction